Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
So now we're going to look at guidelines for how to do the testing, who to test, when to test, how to test. So right at diagnosis, typically we may obtain a family history, but we have to understand that even in the absence of a family history, some prostate cancer patients should absolutely undergo genetic testing. And then the question of workflow as far as whether genetic counseling is available to go over results. So I think there can be some challenges presented based on this kind of more complicated workflow.
I like to perform somatic and germline testing in parallel on every patient that I see with advanced and metastatic prostate cancer. So germline testing is actually now recommended more broadly, almost for every patient with prostate cancer. But somatic testing is really only going to be indicated for patients where that treatment option may affect their care. So in the MCRPC setting, certainly somatic testing may be useful for guiding the use of a PARP inhibitor or a PD-1 inhibitor. And germline testing, again, may pick up those alterations in parallel, but have a different implication, both for family risk, hereditary risk, and risk-reducing procedures and screening for family members. So I always start with some pre-test informed counseling. That this can be done by video. It could be done with a trained genetic counselor. It could be done by the provider, briefly, in terms of pros and cons of the risks of testing, that knowledge, the impact that may occur both on health insurance, life insurance, and what that may do in terms of the benefits, in terms of opening the door to life-prolonging therapies. For tumor testing, it's always going back to what tissue is available. Archival tissue is certainly very amenable without having to put the patient at risk for a repeat biopsy. But archival tissue may suffer from lack of available tissue, from degradation artifacts, from sampling errors, from insufficient tumor content. And so sometimes a repeat biopsy in the MCRPC setting can be very helpful to help guide better somatic testing. We do see that sometimes repeating this will find actionable alterations that were missed in the hormone-sensitive tissue because of issues of evaluability and degradation and clonal heterogeneity, honestly. So liquid biopsy is an alternative way of doing a tumor biopsy just with a blood test. So plasma ctDNA can be done in the MCRPC setting. And again, it may pick up new actionable alterations that might be missed. When you do tumor testing, you will likely also pick up germline tests, but we do recommend doing germline tests separately so that you can really understand from that, the particular hereditary alteration, whether that's present.
So this is an easy one. For somatic and germline testing, all available guidelines pretty much are highly supportive because there are multiple ways that the results will impact patients, their care, as well as their family members. So NCCN, ESMO, AUA, ASTRO, EAU all recommend both somatic and germline testing for advanced prostate cancer.
Easy. So test, and test. For germline testing, again, if you just did germline testing, you'd only pick up half of the patients that would be eligible for the benefits of a PARP inhibitor, not even including potentially the benefits of a PD-1 inhibitor, which can get MSI high prostate cancer. Conversely, if you just did tumor-only testing, you might miss a good fraction of the patients that have a germline alteration because the tumor-only test may pick up artifacts, may have tumor tissue degradation, may miss really pathogenic variants due to sampling quality and tumor quality technical failure issues. And again, I think Tanya's covered this already in terms of the prevalence of these genes, but in terms of rank order, BRCA2, BRCA1, ATM, and many of these other genes are really critical to include in the panel. And just in the past week, JCO has published a very nice article about what genes should be in these panels, and this is really aligned with that data.
The Philadelphia Prostate Cancer Consensus Conference was one of the first to sort of establish these testing recommendations. But as you saw, there's a wide variety of guideline panels that have tackled this as well. So here's sort of the minimum list on the upper right of what germline testing should include in terms of genes. And then, of course, family history may influence it. So it's the benefit of involving genetic counselors who might take a good detailed family history and make sure they include whatever other genes might need to be included. And then, even though we mostly deal with prostate cancer patients, unaffected men with a family history of cancer may also be advised to undergo genetic testing. And so there's a little information that was provided by this conference on that group as well. Localized prostate cancer, germline testing is usually advised for anyone with unfavorable intermediate risk or higher. And in this output, they did include people with intraductal or ductal histology, as well as Jewish ancestry.
So when I take a family history of patients that I see with prostate cancer, it's not just, do you have a family history of prostate cancer, which is a common way I see family history reported, but it's also breast, ovarian, melanoma, pancreatic cancer, Lynch syndrome-related cancers, which are endometrial, colorectal cancer. And a lot of this is unknown. A lot of family members don't talk about their families, they may be adopted, and that's why germline testing is really emerging as recommended for almost all men with prostate cancer. There is a proposal actually to do universal testing. And until that comes out, right now, the guidelines are testing all high-risk patients, all very high-risk patients, regional and metastatic patients, those with a strong family history of those syndromes that I mentioned, particularly if you have a sibling or a family member with known mutations, Ashkenazi Jewish ancestry. There's also some characteristics of patients that might denote a higher risk of homologous repair alterations, such as intraductal or ductal histology. Again, the family history is really critical, and we're doing broad testing, not just homologous repair, but also mismatch repair, HOXB13 testing to really get at the familial risk and then the precision therapies that could lead to the patient doing better. All right, the concluding slide for this section is that, again, germline testing would miss about 50% of the patients eligible for PARP inhibitor therapy. And that's why in the metastatic setting, we do recommend somatic testing. But in the localized setting, for a patient who's cured or very likely to be cured, we don't necessarily need that somatic genetic testing to guide therapy in the localized setting. Tumor-only testing, again, in advanced prostate cancer would miss some of the germline alterations due to issues around tumor content. And so in advanced prostate cancer, where the cancer has spread, where it's metastatic, where it's castration resistant, we recommend both types of tests, somatic and germline. And that is because it can guide directly the care of your patient in terms of approved drugs that are life-belonging, but also can guide familial risk, screening, and cancer interception.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.